Thank you very much. This morning we had a poster tour from 8:30 to 9:30, and I thank the reviewers of the posters, Dr. Sabah Shafak, Dr. Shafiqur Rahman, Dr. Tabir Rasool, and Dr. Terence Gibson, who joined us in the tour. Previously, we used to announce 1, 2, 3, but this year we decided that we are going to recognize everybody, because just the mere fact that the posters, the people, the fellows and trainees worked hard, they made those posters, they made an effort, came to the meeting, is good enough. So first of all, a round of applause for all the contributors to the poster session. We had almost 40 posters and abstracts submitted. Some were case reports, some were prospective or retrospective studies. The notables from Fauji Foundation, DMARD and COVID outcome, use of DMARD's biologics versus and the effect in COVID, juvenile versus adult lupus, clinical characteristics, and gender differences in axial SPA. From CMH Lahore, validation of MIS, a protocol for assessing the side effects of rheumatoid arthritis translated and validated into Urdu, a very good questionnaire. On densitone, use in methotrexate intolerance, and differences between those who tolerated methotrexate and intolerant to methotrexate. From Lahore, National Hospital and Central Park Medical College, we had papers on treat to target in axial SPA and how many patients actually received the target, and the outcome of referrals of uveitis to the rheumatology department, what kind of cases were seen. Similarly, we had from PIMS Islamabad, a paper on thyroid disorders and rheumatoid prevalence, and techniques of shoulder injection, single short shoulder versus 3-point injection. So that was an interesting paper. From Peshawar, we had a paper on the satisfaction of patients using telemedicine. That was interesting. From Children's Hospital, Lahore, we had a series of cases of monophage activating syndrome in systemic juvenile AIA. Since it's a referral center for peds, so they had almost 9 cases. And a case of aortitis, of descending aorta only, in Takayasu arthritis. From Islamabad, Polyclinic Hospital, carotid intimal thickness and risk for cardiovascular disease in rheumatoid, and again, another abstract on thyroid disease in rheumatoid arthritis. A very interesting paper from Quetta, the use of cyclosporin in active rheumatoid arthritis in patients who are undergoing treatment for active tuberculosis. So they have TB, they are on ATT, and our rheumatoid is also active, and so the authors chose cyclosporin as an agent because others were considered likely to aggravate their TB. From AKUH Karachi, Khan University, cardiovascular risk factors in rheumatoid. So all in all, from almost all the centers in the country, we had abstracts, and they were all brilliant. So once again, I thank my poster committee and all of them who contributed. So thank you. And once again, another round of applause for all those who presented in this. Thank you very much.
Our next speaker is Professor Dr. Muhammad Haroon, who is a professor of rheumatology at Fatima Memorial Hospital. Dr. Haroon will be speaking on uveitis and rheumatology.
Assalamu alaikum, everyone. It's an absolute pleasure to have you all here for this SPS symposium. I know that of course, it was written as rheumatology, uveitis, and rheumatology, but I like this phrase more than meets the eye. So I'm going to start with a few short cases rather than talking about the uveitis, and then we'll talk about uveitis, of course, but I'm going to start with a few interesting cases. So this is a young chap who I met, I think it was sometime in 2019. So this guy had quite a severe uveitis, as you can see. Literally, he was on very big doses of steroids. He was extremely Cushingoid. Literally was at times he used to come on a wheelchair because he was so much Cushingoid. You can see like he had almost all the surgeries possibly done because of the complications of the topical steroid therapies. He had the cataract, bilateral visual impairment, and he has been to few of our colleagues, and very rightly so started on all the usual, the steroid-sparing agents, if you like. But again, he was stuck on 20 milligrams of steroids, systemic therapy almost on the daily basis, and still his disease was active. Again, naturally, not surprising, he was a 17-year-old chap, and he was, of course, Cushingoid and depressed, and there was very obvious stunted growth. I wish he could allow me to get his picture, but he didn't. So he met me. Clearly, he used to say, this is not the life. He used to come to see me because he thought there's a new guy in the town at that time, 2019, so he came to see me in PKL at that time. So we started him on Humira at that time, adalimumab. It was a little bit difficult at that time to get, but we managed. So we started on the usual, the steroid, 80 milligrams he got the first, but at times I used to give him the double dose. Of course, it was a little bit of off-label, but again, we used to use it in our uveitis centers. So I gave him a number of times the double dose of adalimumab for a long period of time, 2 to 3 months even. Again, I was very much worried. We used to, rather, I repeated his the quantiferon twice, rather, just because I was concerned. But thankfully, we managed to get on top of his uveitis eventually. He's now off steroids. Again, he's still on methotrexate, of course. Adalimumab, after almost 2 years of treatment, we are on the reducing side. He uses it only once in a month, along with the methotrexate. And this is a happy story about him. So he can see a little bit of future. So this is another case, and this is, of course, referred to me after my talk in my local hospital. So this was the usual, the standard, the 29-year-old chap who used to have some chronic back pain, was considered as non-specific. So after my talk, when he came for another fourth sort of the flare of his uveitis to our ophthalmologist, then they asked me to see, and not surprised, so he does have ankylosing spondylitis. He was started on the standard treatment based on the DUTE algorithm, which I'll just mention in one of the slides. So he was referred to us, rightly so, diagnosed with the SPA, and he's doing better. Has not been started on some systemic treatment as regards biologic, but he's doing good overall. So third case, this is interesting. So this is a 55-year-old lady, had an explosive onset of florid eye inflammation. Literally, there was quite a lot of discharge from her eye. 1 day history, and there was a significant visual loss there as well. And around the history, there was a couple of days history of typical UTI type of symptoms. So she has been treated empirically around that time, the standard antibiotics. So you can imagine that her right eye, there was only hand movements. So within a couple of days we are talking about, there was a lot of damage in the eye at that stage. Was referred, of course, to me because she also had other joints involvement at that stage as well. As regards peripheral joint involvements, there was oligoarthritis happening. So it was what we call reactive arthritis. So just want to highlight that the reactive arthritis-associated uveitis can have a very florid onset, quite explosive onset, and can be quite damaging, and can be, at times, difficult to get there. So she was started on, of course, the standard, the parenteral treatments, and she responded, of course, after some time. So this is another patient, 18-year-old female, HLA-B27 positive, because she has a very strong family history of spondyloarthritis. Her brother and the father both had ankylosing spondylitis. So she had 4 recurrent attacks of acute anterior uveitis. Again, at that time when she came to, of course, see our ophthalmologist, there was surprise there, not that surprise, but again, she had this, what we call cystoid macular edema, means there was a damage happening around that time. So it wasn't a simple acute anterior uveitis. So she was then referred to me at that stage, and naturally there was a lot of concern around that stage. So the question, of course, we were thinking was, should we start? Again, she was already taking intermittent topical steroids. That shall we increase the dose of the standard topical steroids? Should we go with the methotrexate? Again, I, of course, started out on methotrexate along with the parenteral steroids, Of course, naturally, because there was a lot of cystoid macular edema there was a vision loss happening there as well. So just the reason why I put this case here is just in case if we see cystoid macular edema in any of the patients, so we really need to take it a little bit serious. So just a couple of slides on cystoid macular edema, because it was, as we know, there's a little bit of difficulty there at times to dissect out what actually is written on the ophthalmology, their short sort of the notes there. So it's a complication of acute or, of course, the chronic uveitis. It happens because the accumulation of the fluid in the retinal or subretinal areas, and it's the leading cause of the visual impairment which happens with the uveitis. And it's usually associated with the posterior uveitis or panuveitis. We do not see this much with acute anterior uveitis, but if anterior uveitis is associated with HLA-B27 positivity, then definitely the risk of cystoid macular edema is higher. So this is one of our patients, SPA patient, HLA-B27. This is severe acute anterior uveitis along with the posterior synechia as well. And the bottom one, you're seeing the OCT, horizontal OCT picture with the cystoid macular edema. So in this case, naturally, you need to be a little bit aggressive in terms of starting treatment rather than relying on the topical. Either has to be the injection in the eye or some, of course, the usual, our systemic treatments. So where do the rheumatologists come in this picture? Of course, we know that the majority of the patients with what we call non-infectious anterior uveitis would have some systemic underlying cause behind this, and naturally all these patients would require, not all, but most of the patients would require some immunosuppression. So that's why the rheumatologists do need to come in the picture. This is a nice cartoon just to highlight, of course, what we mean from anterior, intermediate, and the posterior uveitis. If there are two subsets or three of all involved, we call this panuveitis. Acute anterior uveitis, of course, is the most common form of uveitis. It presents with the red eye, painful eye, photophobia, and when there are a lot of course, the cells in the anterior chamber, there is a visual impairment as well. Of course, the infections and the other causes, and the neoplastic causes exist as well, but mostly, most of the patients are presumed to be autoimmune in origin, and that's why, of course, a lot of times we see systemic underlying diseases behind this. So this is a fairly comprehensive list, if you like. This all shows the uveitis patients associated with the systemic diseases. And the diseases highlighted in red, these are all the diseases that we see with arthritis and uveitis. And there are only 3 in black where you do not see arthritis. So you can imagine there's a lot of complexities, if you like. So life is not that simple when you talk of uveitis. It's not just SPA. It's not just SPA and this. So just looking at the characteristics of uveitis patients. So if you look at the comparison, for example, these are the 4 different regions of Middle East compared to 4 different European countries. So what you're seeing here, there's very much similarities there. One particular similarity is that most of these uveitis patients are in the 4th decade of life. Little bit of differences, not again surprised there. From the Middle East, of course, the most of the patients have been underlying disease, the Behçet's disease, but in the European population, most of those diseases or most of those underlying diseases were labeled as idiopathic. So that was one of the major differences if we look at the comparison of studies. Of course, we need to be mindful about the impact of uveitis. If we look at the years of the visual loss, the studies have consistently shown that the years of visual loss is very much comparable to the diabetes and macular degeneration, and we all know that 10 to 15% of the patients with uveitis leads, unfortunately, to blindness. This is the study from one of my Dublin colleagues, and he clearly showed that the uveitis patient, compared to the general population, they have the worst social functioning, pain, and of course, the general poor health. Not only they have the worst, for example, the patient-reported outcome measures, if we look at the long-term, for example, the ocular complication. So this particular study, 2019, was published, very clearly has shown that if we prospectively follow these patients, again, this is a retrospective analysis of the insurance claim database. This is what we are seeing here is the survival curve with the hazard ratio of the development of ocular complications from the Cox regression analysis. These are the adjusted hazard ratio, adjusted, controlled, in other words. So what you're seeing here is the hazard ratio of developing any ocular complication is 5.2, or more than 5 times the high risk of developing any ocular complication in the long run if we develop even one or more uveitis episodes. And the same study, they also looked at what they call persistent uveitis, means the uveitis lasting for more than 3 months. In those patients where there was persistent uveitis, the hazard ratio was 9, 8.9 to be more precise. So the 9 times higher risk of developing ocular complications. So what are those complications? For example, again, the same study, when they looked at the usual ones, for example, the cataracts and the visual impairment, we know about the glaucoma and the retinal detachment, but 57.8% of the patients with the uveitis would eventually develop ocular complications, So we need to be very much mindful. And of course, we should not forget about the associated costs, the direct costs, for example, the prescription costs, of course, the consultant visits, and the total indirect costs as well, which are, of course, the absenteeism from the work and the work-related disabilities. And clearly, there's a lot of higher impact of those compared to the general population. So why it is important as got the rheumatologist? Because, of course, the uveitis is a key manifestation, the key feature of spondyloarthritis. It has been given so much weightage that even the SPA classification criteria, uveitis is sitting there. So that's why it is very, very important for us rheumatologists. And we know that in SPA, it is one of the most common extra-articular manifestation. For example, 40 to 50% of the patient with spondyloarthritis would have development of uveitis at a certain time. Of course, with the longevity of the disease, the longer duration of the disease, there's a higher prevalence of uveitis. And this uveitis, again, different subsets of spondyloarthritis, the prevalence varies. And the reason behind is, of course, it reflects the underlying HLA-B27 positivity in these different subset of spondyloarthritis. For example, we know in psoriatic arthritis, there is a lesser prevalence of HLA-B27 compared to ankylosing spondylitis, compared to IBD-related arthritis. So that's why there are subtle differences there. So it's very important that undiagnosed spondyloarthritis is very common in these patients, undiagnosed spondyloarthritis. For example, these two, again, these are retrospective studies, but they have clearly shown that if you look at these patients, more than 40 to 50% of the patients, when they present to ophthalmologists with their uveitis, they would have undiagnosed spondyloarthritis. Means these are the people walking around, but nobody's putting any sense to their symptoms unless they develop uveitis and go to their ophthalmologist, and hopefully they get some clue and refer to us. So this is inflammatory back pain. This is the French cohort. They're looking at following the patient with the inflammatory back pain, looking at the development of, for example, the SPA and so on. So what they're clearly seeing here is they have published a lot of studies from this particular cohort. What they're showing here is that the patient with inflammatory back pain who develop uveitis, they have worse physical health, mental health, and of course the social relationships compared to another person who has just inflammatory back pain but not uveitis. So not only the patient-reported outcome measures in the patient with this spondyloarthritis with uveitis have, but clearly the other studies have also shown that these patients have worse disease activity indices, for example, the BASFI. And not only this, they have a worse radiographic damage as well. For example, the OASIS study has clearly shown. So the patients, in simple words, with SPA, along with the added-on uveitis, have worse clinical and the patient-reported outcome measures. So let's look at the patient journey, for example, to get a snapshot of what happens to the patient before they get a final diagnosis of spondyloarthritis. In our DO-IT, for example, the project, the true prospective studies have shown that 62 to 72% of the patients, 62 to 72% of the patients who had undiagnosed spondyloarthritis, when we look back and ask about who were the disciplines they were attending to, so they had been multiple visits to different disciplines. In other words, these undiagnosed patients that we are talking about, these are not having subclinical disease. They have got active symptoms. They're walking around to different disciplines, for example, the GPs and so on, but nobody's actually making sense to their symptoms. So this is another final product of this collaboration that I must say, of course, that we should all be embarking on is between the ophthalmologist and the rheumatologist. I know it looks complicated, looks like a subway, some roadmap, but this will make you easier that what we should be looking at. So any patient, young patient who has got chronic low back pain, means the back pain lasting more than 3 months, and the age of onset of back pain is less than 45. If they have HLA-B27 positive, along with, of course, the uveitis, they should be referred to rheumatologists. If HLA-B27 is negative, they need to look at whether they have a psoriasis or the family history of psoriasis. Then they should be referred to rheumatologists, and the sensitivity and specificity of these simple two steps is 97–98%. So we also tried to look at how can we predict the future development of spondyloarthritis. We're talking about the uveitis. We're not talking about the undiagnosed. We're talking about the patients who have uveitis, but they do not have spondyloarthritis, any symptoms whatsoever. And we tried to predict that how can we eventually predict that who are the patients who eventually would develop spondyloarthritis. So we sort of more than 120,000 patients with the uveitis we tried to look at. After all the exclusion criteria, there were more than 48,000 patients with idiopathic uveitis were left. And these are the patients who had absolutely no symptoms, no known diagnosis of spondyloarthritis. And then, of course, they were followed up. During those years of follow-up, there were more than 1,000 patients who developed spondyloarthritis. And we tried to predict what were the symptoms. Unfortunately, there was no surprise there. This is a forest plot looking at, of course, the hazard ratios and all this. So what you're seeing here is the most predictive factors were almost, we all know, is the male, of course, the back pain happening in the younger years, and the recurrent acute anterior uveitis, and of course, somebody having psoriasis and IBD. So these are the most predictive factors of future development of spondyloarthritis. So I hope I've made some sense there. I've tried to be on time because I have been reminded again and again to be on time. So the uveitis is not that uncommon. I hope that we all know, especially in the rheumatology world, almost every single week we see new cases of uveitis, at least referred to us. Thankfully, the awareness is increasing among our ophthalmologists. Complications are very common, but they're preventable. I'm talking about the long-term, of course, ocular complications with the proper systemic treatments. It's very important to know our own ophthalmologists, and it's very important that don't leave them alone in managing uveitis. Thank you.
Next, we have a recorded presentation by Professor Dr. Marina Magre, who is Division Chief of Rheumatology at University Hospitals Cleveland Medical Center and a professor at Case Western Reserve University School of Medicine. Dr. Magre's presentation will discuss non-radiographic spondyloarthritis.
Good afternoon. I would first like to thank the organizing committee for giving me an opportunity to present this talk, Non-Radiographic Axial Spondyloarthritis, new name to an old disease. I am sad I'm not there with you today in Lahore to present this talk. As you know, international travel has been a little hassle this year, but I'm more than happy to present it virtually to you, and I hope you're all having a good meeting. These are my disclosures, and the objectives of the talk today are to discuss challenging about this concept of non-radiographic axial SPA, and also to go over how to make this diagnosis, and then finally touch upon the treatment options and some evolving treatments for non-radiographic axial SPA. I'm going to start with the history of how this term non-radiographic evolved. The term ankylosing spondylitis that we are all familiar with was coined in early 1904. Then in 1930, it was recognized that patients with ankylosing spondylitis have an association with this inflammation in SI joints, and this was seen on X-rays. Then in 1961 and 1966, the certain criteria were put together to classify ankylosing spondylitis, and both these criteria included radiographic sacroiliitis, which were then modified in New York in 1984. However, in early 1980s, there were some family studies done on patients with ankylosing spondylitis by one of our own, Dr. Khan, and he recognized with his team that some of these patients had family members that were HLA-B27 positive, HLA-B27 positive probands, had symptoms suggestive of inflammatory back pain, stiffness, fatigue, but did not have changes on the x-rays. So this information kind of, made them think that these criteria that included radiographic sacroiliitis may be limiting, and this disease may be beyond these criteria. And it was in 2009 when the ESAS classification criteria were developed that this term was formally recognized as non-radiographic axial spondyloarthritis. So, based on the 2009 ESAS classification criteria, patients that have chronic back pain that starts before the age of 45 years, and these patients are divided into two arms, an imaging arm and a clinical arm. And patients in the imaging arm had to have sacroiliitis either on an X-ray or on an MRI of the SI joints. So the presence of definitive sacroiliitis is needed for the definition of radiographic sacroiliitis, but those patients that do not have radiographic sacroiliitis, they may have sacroiliitis on an MRI and have one clinical feature of spondyloarthritis, or those patients that are HLA-B27 positive and have two features of spondyloarthritis were classified as having non-radiographic axial spondyloarthritis. You just remember that these are classification criteria and not the diagnostic criteria. The differentiation between non-radiographic and radiographic axial spondyloarthritis, may be important for clinical research, but for us in clinical practice, I don't think we need to differentiate it since they belong to the same spectrum of axial spondyloarthritis. One may be at earlier phase and another may be the later phase of the disease, but they belong within the same heterogeneous spectrum of axial spondyloarthritis. The epidemiology of non-radiographic axial SPA is not well established yet because the disease is very heterogeneous. This was not incorporated in the ICD-9 and ICD-11 codes up till recently. And so based on one study, the prevalence in the United States is about 0.35, which is roughly similar to the prevalence of ankylosing spondylitis, which is 0.35 to 0.5. A large registry in the United States called Corona Registry, which is now also called Corvitas Registry, has shown that non-radiographic axial SPA is more common in females compared to males, and this was also shown in the ProSPA study, which was a study on patients with axial SPA in North America. So what is the role of imaging? How does imaging help us in making this diagnosis? So as rheumatologists, we rely on imaging a lot. So the gold standard for making the diagnosis of ankylosing spondylitis is to get an X-ray of the pelvis. And when we get an X-ray of the pelvis, we are looking for erosions in the sacroiliac joints, sclerosis, or ankylosis of the joint. So we have 4 grades of sacroiliitis: grade 1, grade 2, grade 3, and grade 4. So grade 3 and grade 4 is no-brainer. The joint here is partially ankylosed, it's completely ankylosed here. Once we see this, this is an advanced stage of the disease, and it's very easy to identify this. However, grade 1 and grade 2 sacroiliitis are actually where we run into trouble because we're not quite sure. The findings are equivocal. We may not be sure whether the patient has sacroiliitis or not. And in those patients is where we rely on getting an MRI of the SI joints. So this is look at this X-ray of the pelvis here. On this side, left side, the joint, SI joint looks fine. On the right side, there may be questionable, fuzziness of the margins, which we may call grade 1 or grade 2. And these are the patients who we say have non-radiographic axial SPA. We do not see definite radiographic changes on the X-ray. So when we order the MRI of the SI joint, one needs to order a non-contrast MRI with 2 sequences: a T1, which is a fat enhancing sequence. You see fat in the subcutaneous tissue, and a STIR, or a fat suppressed sequence. But the reason for that is this bone marrow edema on STIR image is a hyper intense signal, and on a T1, it's a hypo intense signal. So we are basically looking for bone marrow edema and on a stir image suggesting that there is osteitis or inflammation in the SI joints. In 2016, ASAS put forward a definition for positive MRI in patients that have active sacroiliitis, and they said that there should be a hyperintense signal on a stir image and usually a hypointense signal on a T1 image, but MRI should be highly suggestive of spondyloarthritis based on the size of the edema, large area of edema, location of the edema. It should be adjacent to the SI joints. It should be intense, and there may be concomitant structural lesions on T1 scan. Other inflammatory changes like synovitis, like capsulitis, alone without bone marrow edema do not constitute positive MRI. Similarly, structural damage like erosions and sclerosis alone without edema does not constitute active sacroiliitis. MRI definition of active sacroiliitis. Patient may have damage, but in order for it to have active disease, one needs to have bone marrow edema on the MRI of the SI joints. This was a recent paper that was published last year by the ASAS MRI group, and they wanted to look how can we increase the predictivity of this MRI for making the clinical diagnosis of axial SpA. And they came up, they said if the bone marrow edema is present in at least 3 or more consecutive slices, that increases the likelihood that this patient may have non-radiographic axial SpA. Similarly, if you see other lesions or structural changes in at least in 4 SI joint quadrants, and the bone marrow edema has to be present at least in one of these quadrants to increase the likelihood of axial SpA. However, is MRI enough to make this diagnosis? The sensitivity of the MRI of the SI joints is very high, but the specificity is not that good. Several studies have shown that patients, like 30 to 35% of healthy recreational runners, 41% of elite ice hockey players meet the ASAS definition for sacroiliitis. Postpartum women with back pain have also been shown to meet the definition of active sacroiliitis. So the study is very sensitive. The MRI is very sensitive, but not very specific for making the diagnosis. So one needs to remember that 2 white spots on MRI is not specific, and it can be seen in healthy volunteers and in patients with degenerative disease of SI joint and spine. This was a study looking at diagnostic utility of MRI to differentiate patients with axial SpA from non-specific back pain. About 187 subjects were included in this study with an age of less than 45 years. 75 of them had established AS, 27 had non-radiographic axial SpA, 26 with non-specific back pain, and 59 healthy controls. About 7% of healthy controls had bone marrow edema suggestive of fulfilling the ASAS definition, suggestive of non-radiographic axial SpA, fulfilling the ASAS definition. And 23% of patients with non-specific back pain. So telling you that this, it's not very specific to non-radiographic. So when interpreting the results of an MRI of the SI joint, please keep in mind the clinical picture of the patient. Patient needs to have other SpA features along with this in order to make this diagnosis. Are there any features that increase the specificity of the MRI? Obviously, if there are erosions in the joints, backfill and ankylosis has been shown to have the highest specificity for axial spondyloarthritis, radiographic axial spondyloarthritis, and on an MRI. If you see backfill is basically what you see is a fatty change within the SI joint, and ankylosis obviously when the joint is completely fused. Higher cutoff for bone marrow edema and fat lesion increases the likelihood that the patient has non-radiographic axial SpA. Low-dose CT is now being assessed to, for letting us know about structural damage. It could be a viable alternative to conventional X-ray. It does not expose patients to much radiation. However, it's only still used in research protocols and not yet available clinically. Are there any laboratory tests that help us? We don't have any specific biomarkers to make this diagnosis, like we have rheumatoid factor, anti This was a diagnostic algorithm that was proposed by ASAS for diagnosing or exclusion of axial spondyloarthritis. So the stem remains the same. Patient has to have chronic back pain lasting for more than 3 months with an age of onset less than 45 years. This back pain has to start early on. And other causes of back pain, like mechanical back pain, fibromyalgia, first need to be ruled out. So the first test that needs to be ordered is an X-ray of the pelvis, looking for radiographic sacroiliitis. If you see on an X-ray that there is sacroiliitis, there is erosions, there is sclerosis, then we can stop there. However, those patients that do not have definite radiographic sacroiliitis, who we call non-radiographic axial SPA, they got divided into three groups. Those that have four or more features of spondyloarthritis, they could have inflammatory back pain with psoriasis, acute anterior uveitis, family history of AS, good response to steroids. They said if there is a compelling history with these patients, there may nothing, you don't need to do much. If there is no compelling history, check HLA-B27, and if it's HLA-B27 positive, you can stop there. Patients with 2 to 3 spondyloarthritis feature and order an HLA-B27, and if HLA-B27 is not positive, they are HLA-B27 negative, then get an MRI of the SI joints. However, patients that have only 0 to 1 features of spondyloarthritis, whether they are HLA-B27 positive or HLA-B27 negative, MRI of the SI joints is recommended, because these are the patients where you want to make sure that there is active sacroiliitis. And I often get a question from some of my colleagues asking me, what do we do in patients who have just inflammatory back pain, but we ordered an MRI of the SI joints and that is normal, and they're HLA-B27 negative. In those patients, I often tell them you could put them on NSAIDs and watch them. They may evolve over the time. But so, do all patients with non-radiographic axial SPA progress to radiographic axial SPA? This is a question often asked by our patients. Am I going to fuse my spine? What are the chances of me having structural damage? So the lifetime risk of progression is about 50%. This is what I tell my patients. There are several studies that have looked at it and in these, and they have found that the rate of progression is about 5 to 12% over a period of 2 years. And there are certain predictors of progression that have been identified in various studies, like patients that have elevated ESR and CRP. These are modifiable risk factors. Patients which have large amounts of edema on an MRI of the SI joints, high spark scores, another modifiable factor. Once we treat them, we can reverse it. Smoking is also a risk factor for structural damage. It has been shown to be in some studies, so I advise patients to quit smoking. Other non-modifiable risk factors are male sex and HLA-B27 positivity. So this is the information I give to my patients. If a patient has a family member that is HLA-B27 positive and has ankylosing spondylitis, and this patient who now comes to us with back pain with positive HLA-B27, there is about 20 to 25% this patient may also have axial spondyloarthritis. Are there similarities and differences between the two, even though they belong to the same spectrum of axial spondyloarthritis? No major differences, except, as I mentioned earlier, females tend to have non-radiographic axial SPA. Elevated CRP is more commonly seen in radiographic axial SPA in AS, and obviously, the metrology index is high in patients with radiographic damage since they have structural damage. Despite non-radiographic axial SPA having shorter disease duration, less burden of structural damage, the burden of disease is similar between the two. The pain scores, disease activity scores are very high in both non-radiographic and radiographic axial SPA. The functional index is impaired in both of them. So one needs to keep that in mind when treating these patients, that non-radiographic axial disease is not less severe as compared to AS. The disease burden is similar and they need to be treated in similar manner or equally. However, women have a unique presentation and burden of disease. They often present most with enthesitis, heel pain, plantar fasciitis, chest wall pain, trochanteric bursitis. They may have peripheral arthritis, predominantly involving the lower extremities, knee swelling. They often get diagnosed as fibromyalgia and psychosomatic disorder. Their inflammatory markers are lower compared to men, and this results in more diagnostic delay in women with poor quality of life. So we previously thought this was predominantly a disease of men, but now with this understanding of non-radiographic axial SPA, we have realized that it is equally common in women, if not more common than men. At present, we have three classes of medications available for treatment of non-radiographic axial SpA. We have TNF alpha inhibitors, we have IL-17A inhibitors, and we have Janus kinase inhibitors. We do not have any head-to-head studies showing us one TNF inhibitor is better than the other. This illustration here, is for this figure here is for the purpose of illustration. And what we see here is that adalimumab, certolizumab, etanercept, golimumab are equally efficacious in patients with non-radiographic axial SpA. In United States, only certolizumab is approved for non-radiographic, but I have been prescribing all the other TNF inhibitors in my patients since they are equally efficacious in non-radiographic axial SpA. And this is no-brainer since it is the same disease as radiographic axial SpA. So these TNF inhibitors worked in radiographic axial SpA, so they have to work in non-radiographic axial SpA too. Are the responses to TNF inhibitors similar in radiographic and non-radiographic axial SpA? There is one study, the certolizumab study, which included patients both with AS and non-radiographic axial SpA. And if you look at the ASAS-40 response at week 24, there was 47.7% response in AS patients compared to 56.5% in non-radiographic at week 24, not a big difference. And the dose that was used here was certolizumab 200 milligram every 2 weekly. So TNF inhibitors, one can presume from this, are equally efficacious in radiographic and non-radiographic axial SpA. This is a very important study I would like to present here. This was an etanercept in patients that were suspected to have non-radiographic axial SpA. They had to have inflammatory back pain, or they could be HLA-B27 positive with one feature of SpA, or HLA-B27 negative with two features of SpA. High disease activity based on patient-reported outcome BAS-DI, and insufficient response to at least two NSAIDs. Only 23% of these patients in the study had a positive MRI, and 13% had elevated CRP. So these patients were treated with etanercept, and half were treated with placebo up to week 16. The primary endpoint was ASAS-20 response, and these were other secondary endpoints. And the primary endpoint ASAS-20 response was not reached at week 16. There was no difference between patients taking etanercept or taking placebo. The mean BAS-DI scores decreased equally between the etanercept and the placebo group. Hence, it was shown that in these patients suspected with non-radiographic axial SpA with high disease activity as measured by BAS-DI, but that did not have a positive finding on an MRI or an elevated CRP, treatment with etanercept was not effective. With these findings in mind, this year, ASAS and EULAR, they updated their recommendations for treatment of patients with axial SpA. 2022 recommendations, they were presented at EULAR. So these, based on those recommendations, patients have to have a rheumatologist diagnosis of axial SpA. They have to have elevated CRP or a positive MRI, meaning sacroiliitis or an MRI, or radiographic sacroiliitis, and have to have failed at least two NSAIDs, and they, with high disease activity, defined as an ASDAS score greater than 2.1, and those are the patients that need to be started on biologic therapy. They also updated that, one of the recommendations. They said once patients fail non-steroidal anti-inflammatory drugs, you could start on a TNF inhibitor, IL-17-1 inhibitor, or a JAK1 inhibitor. They did not give preference of one over the other. However, they made conditional recommendations that patients with history of recurrent uveitis or active inflammatory bowel disease, they prefer monoclonal antibody, TNF inhibitor antibodies, and those patients that have psoriasis, they prefer IL-17-1 inhibitors in those patients. And so IL-17A inhibitors have been shown to be efficacious in non-radiographic axial SpA. Secukinumab, has been tested in PREVENT study. There were two doses used, the loading dose, which is the dark blue, and the light blue is the secukinumab non-loading. There was not a big difference between loading or a non-loading dose, both at week 16 and week 52. So you could choose whichever way you want to use secukinumab in patients with non-radiographic axial SpA. Similarly, ixekizumab has also been tested in COAST-X study, where two doses were tested for ixekizumab, 80 milligrams every 2 weeks and every 4 weeks. It is approved every 4 weeks. So these are the results from this light green here, and is efficacious in non-radiographic axial SpA. Upadacitinib, which is a selective Janus kinase 1 inhibitor, has also been tested in non-radiographic axial SPA, with the patients were randomized either to placebo or upadacitinib up till week 15, and thereafter they continued on upadacitinib up till week 104. The primary endpoint of ASAS-14 was ASAS-40 was reached at week 14, 45% versus 23%, response with upadacitinib. Also, all other secondary endpoints were reached. In terms of adverse events, there were no serious adverse events. Herpes zoster was seen in 2 patients with upadacitinib. Neutropenia was seen in 5 patients, and no flares of inflammatory bowel disease or psoriasis. There was 1 patient that had flare of uveitis in the upadacitinib arm. Tofacitinib, which has been approved for the treatment of ankylosing spondylitis, has been shown to be efficacious with AS, and I will talk about it later, and can also be used in patients with non-radiographic, even though we don't have studies of tofacitinib published yet in non-radiographic axial SPA. What are the emerging treatments for non-radiographic axial SPA? Bimekizumab, it's a monoclonal antibody that is a dual inhibitor of IL-17F along with IL-17A. These were data presented at the EULAR meeting. This abstract showed that bimekizumab, as compared to placebo, was found to be efficacious in patients with non-radiographic axial SPA. At week 16, 47.7% of patients with bimekizumab attained ASAS-40 response compared to only 21.4% with the placebo, and the response rates of other secondary endpoints were also met. With regards to safety, it was overall safe. There were not serious adverse events. The most common, side effects were upper respiratory tract infections. Oral candidiasis was seen in more patients on bimekizumab than on the placebo arm, and this candidiasis was not like mild to moderate, not any disseminated or severe candidiasis. So this question is often asked by our patients: can we reduce therapy once they attain remission? Few studies have evaluated this in non-radiographic axial SPA. Reembark, Ability co-optimized those patients that achieved remission, which was or inactive disease status, which was defined as ASDAS score of less than 1.3. And in these patients, half of them continued on the medication, other half the medication was stopped. And what was found that those patients that stopped the medication, the flare rates were higher compared to the patients that continued the medications. But keep in mind, a large proportion of patients that stopped the medications also remained flare-free. Certolizumab was looked into co-optimized study where they used 2 doses, 200 milligrams every 4 weeks and 400 milligrams every 4 weeks. They reduced the dose of certolizumab from 200 every 2 weeks to 200 every 4 weeks, and they found that 200 every 4 weeks was as efficacious as 400 milligrams once a month for preventing flares. So giving us an option that we could reduce the dose in patients that have achieved remission. So the take-home points are: non-radiographic is not a separate disease, but a spectrum of axial SPA. Early recognition and treatment is critical. Radiographic progression is variable in non-radiographic. Availability of MRI has revolutionized, but the findings have to be interpreted in the context of entire clinical picture. And we have 3 classes of medications now available for treatment of this disease. And thank you for your attention, and I will be available for any questions.
Thank you so much, Dr. Marina. The next speaker for this session is Dr. Salman Khan, who is currently a consultant rheumatologist at Kulsoom International Hospital, Islamabad, and Afridi Medical Complex, Peshawar. I'd like to welcome Dr. Salman Khan onto the stage to speak on disease modification in axial spondyloarthritis and what does the future hold. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I know you all must be waiting for the lunch, but bear with me for the next 10, 15, or 20 minutes. Disease modification in axial spondyloarthritis, what does the future hold? Earlier on, Marina McGray sort of elaborated quite nicely and thoroughly, rather, in terms of the different disease aspects of spondyloarthritis, particularly focusing on non-radiographic axSpA. So when we talk about axial spondyloarthritis, there is always this difficulty in terms of diagnosing in time and in a condition where you are coming across difficulty even with MRIs. So you are thinking that, dealing with this sort of condition, the initial diagnosis in time and the diagnostic delay that we often see in our clinical practice is something quite a bit of challenge for a lot of rheumatologists for that matter. So looking at plain X-rays, when we talk about diagnosis, different radiologists, or for us as clinicians, as rheumatologists, one can argue that whether it's a grade 1 or grade 2 sacroiliitis or the changes that we see in, on a plain X-ray. And that's quite difficult in a place where you don't have many people with training in MSK radiology. A lot of these radiologists will be sort of general radiologists, and sometimes there is problem with the expertise as well. So this modified Stoke AS spinal score, the MSAS, it actually is looking at the interior aspect of the spine and grading it, giving a score from 0 to 3 with a total score of up to 72. It is sort of, in a way, labeled as a scoring index for disease progression, rather, in a lot of the studies that I'll be taking you through in the next few slides. So what does the future hold, really? I personally would feel that if we can get an MRI scanner, or any scan for that matter, which can print a direct sort of report for us, like the way we get in echo and lung function tests, and it can, through its own sort of understanding of the anatomy or the changes or inflammation, give us a report. Because there is quite a bit of variation in reporting and understanding of the problem itself when it comes to radiology. But certainly MRI, CT, and PET-CT will have a role down the road. MRI we still use nowadays. And if you look at these pictures, the upper ones are for healthy individuals, and the lower ones are for a patient with axial spondyloarthritis. On the very left side, you've got MRI images, and then a CT, and then an MRI with VIBE, which is the volumetric interpolated breath hold images. And as you can see over here, on the VIBE sort of images down here, it is sort of highlighting the cartilage in a better way. So it's rather easier for us to understand that, whether there are any erosions or any changes over there for that matter. And certainly looking at the CT also, it can be useful. You can see the changes over there as well. But beyond that, there is this MRI-based synthetic CT to detect structured changes on these images. So for example, looking at this one, this is a CT. This is an MRI, which is sort of formed through artificial intelligence, as they call it. Over here, this is a conventional MRI, but here you've got a CT. And for us as clinicians, perhaps this is the right sort of image to look at, and a little bit easier as well to understand whether there are sort of any erosions or any changes for that matter. And of course, you'll be taking clinical sort of history and examination. Nothing can replace that. But the imaging will help us in a better way. And this is something Marina earlier on alluded into as well, the low-dose CT versus conventional radiography of the spine. And it is actually sort of giving a score from 0 to 14. So the more you have greener sort of shadows, the better it is. And obviously, this particular picture shows more reddish sort of areas in the thoracic spine, suggesting that perhaps there are more syndesmophytes in the thoracic spine. And then better quantification with the syndesmophytes growth in axial SPA with the CT as well. So the MSAS actually is looking at the anterior, this part of the spine through plain radiographs, but the CT here in this particular picture is looking at the posterior aspect as well, so perhaps a better way of evaluating our patients. And then the role of the PET CT is there as well. With the PET MRI, you can see that the spine is all on fire and there's a lot of inflammation going on, and quite easy for us to understand as well. And obviously, nicely, hopefully reported by the radiologist as well. And with the PET CT, there is more sort of expertise required as well. One of the difficulty with these cases is that, for example, if you look at the sacroiliac joints, there might be a little bit of wear and tear or degeneration as well. And if there is not so much expertise in reporting these scans, it may be sort of taken as inflammatory sacroiliitis rather than degenerative sacroiliitis in patients such as postnatal sort of ladies with multiple pregnancies and pelvic instability sort of syndromes. This is a scan which is sort of telling us pre-TNF and post-TNF. So after the TNF use, there is more sort of resolution of the inflammation along the spine, although the lower spine is still affected. So it can tell us the extent of inflammation in the spine as well. So beautiful images, but the difficulty with PET CT, as you all would agree, that we do not have much access to PET CT. I actually suggested a PET CT for a patient with a vasculitis once, and the patient never came back to see me because the cost is 60 to 70,000 rupees, I think. And it's only available in a few centers, mostly used for cancer patients. And this question in clinical practice is rather important, and a lot of the times now patients are more intelligent. They read about their condition, and they will be asking us from time to time that what is their prospects, what is their future, what is their sort of job prospects, their personal life, their mobility, their sort of day-to-day activities. So it is rather difficult to sort of tell individual patients that, how you actually would be in 5 to 10 years' time. But there are a few things that we certainly can take into consideration. But looking at this particular slide, you can see that some of these folks, that they are progressing quite rapidly. So the MSAS is sort of going up at an earlier sort of stage in comparison to these ones who are sort of slowly progressing, and the deterioration in the spine, in other words, the syndesmophytes formation is rather slower. So there are a few things that we certainly can take into consideration. Obviously, if they have raised inflammatory markers, if they are smokers, and if they have syndesmophytes present at the outset, at the start of their problem, then they will be sort of lying here in this red box. But if they are non-smokers, if they have no syndesmophytes present at the start with normal CRP, perhaps they will do better over the course of, I've just have started, they have to wait. So there is this sort of like these few things that we can sort of take into consideration when we are dealing with our patients. So what does the future hold really? Obviously, there is imaging things, the precise prediction of structural damage, progression, biomarkers, genetic factors, and imaging, etc. These all are important. Now, one of these things which are now sort of coming into focus is the fibrinogen. So if there is a loose fibrin clot structure, as they call it, then it can perhaps trigger the inflammation a lot more in comparison to the tight fibrin clot structure. So these are more histopathological sort of factors which are important and which will perhaps help us in understanding the progression of inflammation. So there you go. If you have tight fibrin clot structure, then it stops there and the inflammation does not really progress as we see in loose fibrin clot structure. But beyond that, there is this type of wild type of fibrinogen. So if somebody has got raised CRP, for example, in this particular instance, more than 10 milligram per liter, per whatever, and if they have wild type of fibrinogen, then the odd ratio of the 2-year progression of the MSAS is rather higher. You can see 6.86 over here in comparison to the other figures. So it really depends on the type of fibrinogen there as well. So these are sort of studies for future, which needs to be sort of done with more studies and more evidence. When we talk about anti-TNF, do the anti-TNF really stop the radiographic progression? Perhaps yes. But this one actually said that it did not really sort of stop the disease progression by using etanercept, infliximab, and adalimumab. One of the problems in this particular instance was that the disease duration was just, the study was carried out over 2 years, and then those patients had more advanced disease as well. So sort of, reaching to that conclusion perhaps was not so true. But what we know of use of anti-TNF is that if you start these medications early with a disease duration of less than 10 years, as depicted by this particular line, then the progression of the MSAS is rather slower. So the earlier you start anti-TNF, the better your patients will be in the very long term, as compared to if you start these patients on TNF after more than 10 years of duration. The better you control the inflammation, the better it is, and it will definitely suppress and give you a better ASDAS of less than or equivalent to minus to 1.3. But certainly these new molecules, for example, the IL-17 has a role in stopping the syndesmophytes formation. So here you see the IL-17 users, they are actually sort of suppressing the newborn formation as shown in the spine and in the ankle. So these molecules are good, and you certainly can sort of think about using these when you are dealing with these patients, and certainly I personally have got good experience with secukinumab. The radiographic spinal progression up to 4 years in patients with AS treated with secukinumab. So remember that, 2 years is probably an earlier sort of commenting on the efficacy of these molecules. You probably need a little bit more time. So after that, you can see that the secukinumab, when used in 75 milligram subcutaneous injection in comparison to 150 milligrams, this is the 150 arm, this is the 75 one. So after 2 years, you started sort of, you will start seeing the difference. It is not that these medications do not help at all in prevention of syndesmophytes, but perhaps it takes a little bit longer than you would normally expect. And certainly, kuzumab has got a role as well. As you can see that it has sort of a role in changing from baseline of the MSAS as well. So what does the future hold again? Well, new modalities to reach to a diagnostic conclusion, and precise prediction of structural damage progression, biomarkers, genetic predictors, and imaging, and prevention retardation of structural damage progression, especially in high-risk patients. So should we really use non-steroidal anti-inflammatories? Well, you perhaps can, but if the sort of outcomes are variable, and it really depends on your patient perhaps as well, whether they had raised inflammatory markers and how active the inflammation was. So if you use them, these probably will help, but it does not necessarily mean that it will have the same outcome in every single patient. Secukinumab, in comparison to adalimumab, has proven to be sort of having some superiority in terms of proportion of patients with non-radiographic progression. So these are molecules, and you can use them from time to time, and certainly looking at your patients and individualizing your patients as well. So in summary, imaging techniques are valuable to assess structural damage and disease progression in expa. Genetic determinants should be sort of taken into consideration. The fibrin is there as well, and effects of NSAIDs on structural damage progression has been varied, and the SURPASS is the first head-to-head study evaluating secukinumab versus adalimumab biosimilar with MSAS as the primary outcome. So it really, it is a difficult sort of area which needs MDT and a coordination with our radiologists and better understanding of the disease pattern, which will help us managing these patients. But certainly we need to think about the future, how to be more robust in diagnosing them and managing them. Thank you.
Thank you, Dr. Suleiman. For the next talk, I'd like to invite Professor Dr. Muhammad Haroon back onto the stage on the impact of interleukin-17 AI in synovitis reduction in PSA patient learning from the ultimate study.
Assalamu alaikum, everyone. So back again. वो कहते हैं ना उसको छुट्टी ना मिली जिसने सबक याद किया. So पहली talk I finished on time, rather little earlier time, and I'm told now that I need to finish even earlier than the first one. So officially I was given only 10 minutes, now I'm told to finish even earlier, so I'm not sure how I'll be able to manage. So the talk is about IL-17. So I'm not just going to talk about this particular study. I'm going to help all of us learn about this particular cytokine, which we should all be excited about. These are our disclaimers. So of course, we'll be talking about psoriatic arthritis. Being a heterogeneous disease, we know that there are a lot of unmet needs. We know about the diagnostic delays, and we know about the structural damage. A lot of studies across the world have shown that around 40 to 50% of the patient who present even at the first visit to a rheumatologist would have some structural damage already there. And it's always a challenge that how can you predict the treatment response. So again, against all the odds, against all the clinical challenges which are happening there, the good news is that the therapeutic landscape in the world of psoriatic arthritis is increasing very, very rapidly, I must say. This is a slide of 2015. So this was around the time I think we had a presentation at ULR, so we made this. So we were all mesmerized even at that time that where the future will hold for psoriatic arthritis. We were all happy that the new molecules are being inhibited, and there was a lot of good response. And there was a lot of drugs even at that time which were on pipeline. And this is quite a latest one. And you can see now we have got a lot of other drugs to hand. We have got JAK inhibitors. We have got IL-23 inhibitors. The one is we know is in use. There are other two which is going to be licensed soon enough. And of course, we know about for example, the T-cell inhibitors, they're also being licensed. So if anybody who fancies to learn more about the new drug developments, whoever is attending the APLAR, I have a talk there about the new drug developments which are going to be in pipeline in the next few years to come. So without a doubt, the major breakthrough when you talk of the pathophysiology and our understanding of all these innate immune system and how they crosstalk with our adaptive immune system come with Th17 cells. So we know about, for example, the antigen presentation to the dendritic cells when they present to your helper T cells. And then, of course, we know about since 1989 that we have got Th1, the gamma interferon producing, and we also know about the Th2, which is IL-4, which helps for the humoral immunity. But in 2000, I think it was around 5 or thereabouts, when formally they recognize about what the Th17 cells are and the IL-23, which of course is the main differentiating cytokines for Th17. And within a few years, you'll be amazed that there were efforts that how can we inhibit Th17 cells. So this is a little bit of that axis, if you like, IL-23. IL-23 comes from, we know the dendritic cells and mainly the macrophages are the main cytokine IL-23 producing cells. And IL-23 is the main differentiating cytokines towards the production of your Th17. There are other factors as well, for example, IL-1 beta. There are also IL-6 as well and the TGF-beta, but IL-23 is the main one which differentiates the Th17 and further downstream cytokines. We all know about the IL-17 and of course the other one is IL-22 as well, and which leads to the whole cascade of pathological events leading to the radiographic damage and so on. But the story gets very much exciting when you started looking at the studies which are coming that we know about the TNF, of course, but let's look at IL-23. We thought earlier on, there was a lot of talks I'm talking about in our sort of the world when we were talking about IL-23 inhibitors. It was considered that probably it's a duplicate target. that IL-23 and IL-17 blockers, probably that doesn't make sense. These are duplicate target because we're talking about the upstream is IL-23, downstream is IL-17, so probably it would be the same response. But surprise, what we see is that when we blocked IL-23, the response is not the same. What I mean from that is there was absolutely wonderful response, better than IL-17 in terms of the skin. But when we started looking at the spinal disease, the response with IL-23 blockers wasn't there. So IL-23 blockers are not helpful when we talk of the spinal disease. But when you talk of IL-17, for example, it was an absolute wonderful, absolutely zabardast response when you talk of the inflammatory as regard the spinal disease, enthesitis, and so on. So there was clearly some differential sort of the response coming from these. And then some sort of the understanding happened when they looked at was that the Th17 are not the only sort of the mother of IL-17, if you like, because there was a lot of other IL-23 independent sources of IL-17, and these are all, we know about the innate immune cells, which are the resident innate cells in our soft tissues, for example, the enthesitis and so on. And they're the one which crosstalks with our immune system. So this is a little bit of the timeline. If you look at, for example, IL-17, we knew about the IL-23 a little bit earlier, but we weren't like sure where to fit in this IL-23 in this whole story of Th1 and Th2. So IL-23 wasn't fitting in the whole sort of the scenario, but it was until Th17 cells were recognized and the story was much more clear that how they crosstalk. And as I mentioned, for spondyloarthritis were the IL-23 and of course the IL-17, which are of course the adaptive immune response cells that they crosstalk with our innate immune cells. As I said, 2005 was the one when Th17s were recognized, and literally within 2 years, they were like this, the secukinumab, for example, and the other inhibitors were out, and the phase 1, 2, 3, and so on studies were out. And 2015, within 10 years, there was a formally licensed IL-17. So we know about the IL inhibitors, you know IL-17, they're all in, for example, licensed, and they do wonder as regards the 6 domains of psoriatic arthritis. And let's look at that, can ultrasound make things invisibly visible? Means we know from the clinical studies that of course they're absolutely wonderful as regards standard joint count, swollen joint counts, and so on. But when we look at how about when we do the ultrasound studies on them and to see whether do we get the same response, means to look at the objectivity of the clinical response in simple words. And of course we take the example of peripheral arthritis, peripheral synovitis, getting their ultrasounds. We know about the B mode ultrasound. Of course we look at the morphology, look at the erosions and all this from the B mode. And we know from the power Doppler, we look at the active inflammation, just like bone marrow edema, in other words. So here we look at the power Doppler to look at the active inflammation happening. And it's absolutely wonderful if you look at the power Doppler that from the skin, underneath the enthesitis, peritendon areas, osteitis, so literally all sort of things that we get fancies about in spondyloarthritis or psoriatic arthritis, we can get this detected from this power Doppler. So believing so much in this, you know that there's a lot of criticism about this, about being operative dependent, because of course it all depends who the person is and what they're doing. So looking at this, the EULAR and OMERACT have got now this reliable and reproducible and sensitive scoring system for this power Doppler ultrasounds synovitis score. So I'm not going to bore you with all this, but there's a lot of talk about, and this very sort of latest data that how this transition happens when we look at from psoriasis to psoriatic arthritis. We know about there are 3 clinically silent stages, if you like, from preclinical, subclinical, and there's a little bit of the prodrome phase as well. But the ultrasound, for example, can be extremely helpful when we talk of the subclinical disease, where there might not be that much symptoms. So I'm just going to highlight that the power Dopplers and of course the ultrasounds can be very helpful even in the early disease and of course in the established disease. So as I said, having so much sort of success and of course the reproducibility of this particular ultimate study was designed, and this is the only, as we speak, is randomized control trial, placebo-controlled trial, where the power Doppler ultrasound signals were used as the primary endpoint rather than the usual ACR criteria. So the power Doppler ultrasound was considered as the primary endpoint. So So this was a placebo-controlled trial. In first 12 weeks, there was, of course, the placebo arm and, of course, the active drug, which was a secukinumab. After 12 weeks, then the patients on the placebo were switched on to the active drug, and then they were prospectively followed up to 52 weeks. So very much similar to if you look at the response from the ACR criteria and the clinical studies, which we know from the original studies of the secukinumab. We are seeing very much similar response. The response within first week of that there was a power Doppler ultrasound reduction after giving secukinumab compared to the placebo arm. And after 12 weeks, when the placebo arm was switched to the active drug, and we're seeing that the same response is that the good response comes, the power Doppler ultrasound signals are much, much more less, and they continue to improve up to the 52 weeks follow-up time. So again, as I mentioned, there's a lot of things that we should be talking about, and that is how can we predict about the particular treatment response, and looking at whether ultrasound can help us about this particular dilemma, if you like, that which patient would be targeting, or which patient should be giving the best treatments as soon as possible. So this particular study, they did the cluster analysis. So it means they divided patients into 3 groups. One was cluster 1, 2, 3. So the cluster 1 was the patient who had got quite intense power Doppler ultrasound signals, but mainly in the peripheral joints. And there was cluster 3, where there were also quite a lot of intense power Doppler signals, but more in the smaller joints. And the cluster 2 were the patients who had a relatively lower end of power Dopplers, means they had, as per the ultrasound, lesser level of disease activity, in other words. I'm talking about the power Dopplers. When, of course, these patients were followed, again, we are seeing, not surprise, that the patient who had got intense ultrasound signals, increased disease activity, when they were given secukinumab, there was a major reduction of inflammation compared to the cluster 2, where there was a much lesser power Doppler ultrasound activity. Again, not a surprise, but it's very nice to see the objectivity of the response rather than just looking at the tender joints and so on. So to conclude, IL-17 I think is one of the major breakthrough. There's a lot to learn, and there are more studies on the way. And power Doppler ultrasound is a very reliable, and I think we should all be, I know the timing is always difficult, is a challenge in our routine clinic, but it does give the objectivity of when we examine our patients. Thank you.
Thank you so much, Dr. Haroon. The last speaker of the session is Dr. Mazali Abbasi, who is a consultant musculoskeletal radiologist practicing at University College London Hospital, NHS Foundation Trust, Spire St. Anthony's Hospital, Princess Grace Hospital, Harley Street Clinic, and the London Clinic. Please welcome Dr. Abbasi, who will be speaking on imaging in spondyloarthritis.
The annoying one who has the Mac. Just press that, that should be okay. Is that all right? Yeah. Okay, cool. Assalamu alaikum, everyone. Organising committee, ladies and gentlemen, thank you ever so much for the opportunity to present to you just before lunch on this topic. It's always a pleasure being back in Pakistan. Although I've grown up in England my whole life, coming back to Pakistan always feels like I've come home. So the topic of my lecture is advanced imaging in axial spondyloarthropathy, but actually I think the real topic is simply eyeballing images good enough in the 21st century? I'd like to give special thanks to our team at UCLH, including my fellow Natasha, Dr. Tim Bray and Professor Margaret Hall-Cragg, who leads our department. I have no significant disclosures. The objectives today are really to go through some of the traditional MR techniques, some of which you've heard about earlier today, but I really wanted to tell you about some of the newer things on the horizon, which I think will really play a huge part in the next 10 to 20 years with advancements in MRI technology. So does anybody know what this is? No. This is the first ever radiograph taken. X-rays were discovered by Willem Röntgen in, I think it was about 1901, and he discovered a new invisible energy that was able to penetrate through structures and produce an image. And so, as any good scientist does, when he discovers something new and he doesn't know whether it's safe or not, he did what any loving husband would do. He thought he'd try it out on his wife. So this is his wife's X-ray. So she has the first ever X-ray ever taken. I think she survived, and I don't think she got any tumors from it, but that's the story of X-rays. And really, it changed everything in medicine, and in particular in rheumatology. I don't know if we can have the lights down a little bit, but you can see this is where we started off with plain radiographs of the spine, which was obviously an incredibly valuable tool, and I think we heard earlier from the professor from Cleveland about the usefulness of radiography in rheumatology. But I would say that that's really out of date now, because you can see that with newer, and this is just normal conventional MRI. I mean, everybody here, pretty much everybody here will have access to MRIs like this. This is a standard T1 turbospin echo sequence, and this will be a stir. And this is what you guys will be comfortable with looking at. I'm sure most of you will be comfortable at looking at these sorts of images. And likewise, in the sacroiliac joints, you can see this is what the radiograph would look like. Of course, it's quite obvious in this case. You can see the sclerosis, you can see the erosions. But with the MRI, it's just a lot better in being able to see not only the structural damage, which one can see on the T1s, which you can see, for example, the periarticular fatty metaplasia, but also you can see that there's no active inflammation at the moment. So you get two bits of information using the MRI compared to the X-ray, where you're only really getting structural information, not so much about inflammation at the time. And indeed, that's reflected in the British Society of Spondyloarthritis guidelines, which actually, interestingly, say that imaging is only one aspect of the diagnosis. So the clinical aspect is still very, very important, and in many ways still trumps. I think one of our colleagues came and asked me earlier that, how important is the imaging? Can we have normal imaging and then still have active inflammation? And I think the answer has already been answered in the earlier lectures, which is yes, it can. So your clinical acumen will still trump what we see on the imaging, but it is a very important asset. So let's look at what the traditional paradigm is of what we do in imaging. We acquire a number of images or sequences which are weighted according to different property types, and you will do a set of sequences, maybe 4 or 5, takes about half an hour. The radiologist opens the PACS system, a digital record of the imaging. He looks at each sequence, and then he produces a qualitative report, a written report which you will then read. However, is that good enough? Because the big problem with that is subjectivity. Because somebody might have a look at something and may look at it later on in the same day and come to a different conclusion. It happens. I take the MDT every week, and there are times where I look at a report and say, I completely disagree with this report. I scroll to the bottom and I realize it was my own report. So I'll disagree with my own report, and then I'll disagree with other people's reports. So is this good enough for the 21st century? And are there ways that we can find more objectivity and an independent review of the imaging? And that's where something called quantitative MRI might have a significant impact on what we do in the future. Because what we're doing in quantitative MRI is that what we do is that with a single weighting, we can acquire multiple echoes. And what this then allows us to do is to analyze the tissue and get real tissue properties, and we get a parameter map. And then we're able to get a quantitative analysis. Now, a lot of this sounds like mumbo jumbo, but I will explain what we do in a minute, which will make it very clear. But the point being is that rather than having just a qualitative assessment of seeing a focus of bone marrow edema, for example, one will be able to get an actual numerical value, which would then have the potential to be followed up over time to gauge the response to treatment that you might be giving. The other advantage is that a person might be able to do more other quantitative analyses, such as measuring fat fractions, which again I will touch on in a minute. So this is a very wordy slide. Please don't try to read it, but there are two principles that we're going to discuss today. Number one is about quantitative MRI, which is the ability to extract a numerical value from your MRI image, and quantitative biomarkers, which is a bit more complicated, but essentially is the potential using quantitative MRI to objectively measure characteristics derived from your image and use that as an indicator of normal biological process, pathological process, or response to treatment intervention. So the point essentially here is that we can use that as a means of measuring treatment, response to treatment, and also guiding your therapy. Now, there are a number of different techniques that are being used at this moment in time, not necessarily in clinical practice, but certainly in the research realm, that one can use to get quantitative MRI. I won't be able to go through every single thing in detail, but these are essentially the main ones, which are diffusion-weighted imaging, intravoxel incoherence measurement, which is an advanced version of diffusion-weighted imaging. I'm not going to speak too much about that. Relaxometry, this is chemical shift MRI. I will talk about that in a minute, and also dynamic contrast enhanced MRI. So let's talk about chemical shift MRI, because this is at UCLH. I think maybe I'm being a bit too forward, but I think at UCLH we're probably the most advanced at doing chemical shift MRI than any other center, certainly in London, I would say, because of people like Professor Hall-Craggs. But essentially, this was a technique that is a natural phenomenon that occurs at proton level. And actually, it was Dixon described this technique in 1984, but he didn't really know what to do with it until now, when our scanner technology and our advanced techniques have allowed us to exploit this natural phenomenon. And that natural phenomenon is that when you excite water and fat protons, so going back to the original thing, on the assumption that all cells are essentially produced with either water cells or fat cells in most tissues, or a percentage or a mixture of the two, if you excite the protons, the water and the fat protons, and you measure the echo, i.e. you receive the signal back after exciting those protons, if you measure them at smaller intervals, a very small fraction of intervals, what we find is that the water and fat signal separates. They're not exactly the same. There are subtle differences in the times. So there are times during the cycle where the two protons are exactly opposing each other. So this is a summated image. This is when the two protons are facing in the same direction. And you measure it a few seconds later, and they've now gone 90 degrees to each other, so they're perpendicular. Measure it a few milliseconds later, and they're exactly opposed to each other. What's the advantage of that? Well, the advantage of that is that what we acquire is a signal where the two protons are giving a summated image. So that is fat and water combined, giving us a single value. Okay? But when they're exactly opposed to one another, then actually the signal value reduces. But in addition, you get signal only in this scenario from your water proton. Okay? You're not getting any signal from the other proton. So what's the advantage of that? Well, what the advantage of that is that you can then separate out the two protons. And instead of doing what is a stir image, and we've heard lots about stir today, because everyone likes stir, because it's nice and easy and we can look at the images. And what stir essentially does, all of these techniques that we're talking about, what they're essentially trying to do is to suppress the fat. That's what we're trying to do, because marrow is fatty. Normal marrow is fatty, generally, in adult population. And what we're looking for is water in the protons, water protons, and that's why we have different techniques to suppress the signal from the fat. And in a stir, that's what we're doing. I won't go through the physics of it, but that's essentially what we're doing. What we're doing in Dixon is slightly different. We're not trying to suppress the fat image. In fact, what we're trying to do is to harness the fat image or collect the signal only from the water. So here's a stir, and here's a Dixon of exactly the same person. And you'll say, well, what's the difference? Well, let me show you what the difference is. In the stir image, because the protons are subject to the magnet has field inhomogeneity, i.e. it's not a uniform magnet. When you try to invert or remove the fat signal, small errors within the calculation can lead to inhomogeneous fat suppression. So when we look at the fat here in the gluteal area, or in the sacral area, you can see it's slightly brighter here. And then it gets darker. You look at the bone marrow signal here, it's brighter than when you get up here, it gets darker. But when you look at a Dixon, because you are only collecting the signal from the water, this is a water-only signal now. So you haven't got an issue of getting inhomogeneity in your signal that you've got. Actually, what you're collecting is only water proton signal. And as a result of that, if you compare the inhomogeneity of this to this, you'll see that this is far more homogeneous. The fat signal in the marrow is far more homogeneous. It means that when you see hyperintensity in that signal, you know that's going to be coming from the water and not from anything else. It's a very simple technique. It can be done on virtually any scanner, a 1.5 or a 3T, doesn't make a difference. It's not a particularly complicated thing. It just needs to be set appropriately. And this is what you're able to acquire. So this is now a water-only image. And the inverse of that is a fat-only image. So now you can see all the signal that's coming from the fat is nice and bright and white. And what's the other advantage? Well, the other advantage is that you can then calculate a fat fraction. Each voxel, you calculate the fat signal and the water signal from each individual voxel. That is a pixel in 3D, it's called a voxel. So you can collect that information. So here is a fat fraction of a conventional MRI. When we're looking at the edema signal, we can actually see that the fat fraction reduces because the water content has gone up, okay? So the fat content has gone down, and so that reflects in the numerical value. You can set the values from 0 to 100 or 0 to 1 as they have done here. So a 0 means this is predominantly water, not fat, okay? And similarly with fat metaplasia, if you look at this is a traditional T1 signal. Again, you can calculate the fat fraction, and this can be used as a mechanism to measure response to treatment. And then you can do a whole body image, and you can then use specific software, a software called Ideal, which then allows you to calculate these massive fat fractions. This can be used even in bone marrow imaging when you're measuring for osteoporosis. The second technique that I want to spend time on is diffusion-weighted imaging, because this really revolutionized imaging, certainly in neuro. It's completely changed neuroimaging forever, but now increasingly we're applying it to a lot of other conditions, but in particular in rheumatology, it's been very, very useful. And this is based on essentially protons moving in Brownian motion. That means that every proton is moving in water or gel or somewhere where you've got free diffusion. The protons will be moving in random directions. The probability of a proton moving in any direction is as much as a proton moving in another direction. In normal parenchyma, the extracellular water is restricted slightly because there are big cells in the way. So the water diffusion is restricted to a degree. However, when we have hypercellularity, so for example in tumor cells, when we have an increased number of cells, or in inflammation where we have increased cells in an exudate, then free water diffusion becomes restricted. And that manifests as hyperintensity on your scan or increased signal on your scan. The other way that you can have restricted diffusion is if each individual cell swells. And this is what happens in an infarction. In brain infarcts, the brain parenchyma expands and swells, and therefore you have restricted diffusion. What does that result in? The problem with that, however, from that signal, is that the signal that's retrieved has inherent T2 weighting. I won't go into too much detail about that, but you have to correct for something called T2 signal, which is in your signal that you've acquired. Normal signal, if you look, oh, by the way, to get your diffusion, you apply a gradient across the cell that you're trying to image. 0 gradient up to 1,000. These are high B-value gradients. And what we see is that the signal in CSF, which has essentially got free diffusion, the signal is lost very quickly as you go to a higher B-value. Okay? In normal tissue, the curve is a straight flat line. But when you have pathology, the gradient is reduced somewhat. Now, what we're looking at, what we do with our diffusion values is that we calculate the gradient. So we get this graph, we measure at a low B value and a high B value, and we calculate this gradient. And we know that pathological tissue has a lower gradient than normal tissue, and therefore appears slightly grayer. And that's what allows us to know whether there's actual pathology there. So what are we able to do? Well, in chronic active synovitis, you can see this is a different technique of fat suppression. This is called fat-saturated T2, so this is an alternative to stir. Again, you get inhomogeneous fat suppression, but you can see that there is edema, clearly periarticular edema in that left sacroiliac joint. But that correlates very nicely with the diffusion. But what you're able to do, because we have quantitative measurements, as we've seen here, we're able to do a region of interest and calculate the percentage and get a value there. We're able to actually get an absolute numerical value there, which means that if you measure across different B values, you can actually get a quantitative measure using the diffusion. And what does that result in? Well, it results in us having the ability to do quantitative MRI. If we do a number of diffusion signals and we harness that signal, so this is a stir, then we can get a number of numerical values on the ADC map and then calculate that. And that can be used not only for making the diagnosis, but also for measuring the response to treatment. Another technique that we've been able to do is measuring the rate of loss of signal. So we weight the signal to a T1 or a T2 or a T2 star, and we do multiple acquisitions over time to create a graph. And we measure the gradient of loss of signal. And in doing so, with those multiple echoes, we're able to get a numerical value again to get a map, which we've got on this side here. Another technique that we can do is dynamic contrast enhanced imaging, which is where we place a region of interest in an area that we're interested in looking at. And then we apply the contrast, intravenous contrast, and we measure at this point again and again and again, and we get curves of enhancement at these particular sites. Again, you get a quantitative measure of the actual enhancement, not just a qualitative image. And then overlay that with AI, and you get even more objectivity. Because rather than having a human looking at that and apply a region of interest circle, like we did here, if you use AI and overlay AI over that, the AI is able to detect the joint and able to then create its own region of interest and therefore results in a numerical value. And using deep learning algorithms, we get further correction because, again, this is all now becoming automated. So this is a semi-automated analysis using deep learning. Again, it takes the human factor out of the analysis because the AI will be doing that for you. So in summary, there are a number of different techniques that are out there. There are drawbacks. There are drawbacks to all of these techniques. So for example, with diffusion-weighted imaging, as you can see earlier, the spatial resolution is quite poor. So it is susceptible to movement. So if a patient is lying there and these scans are going to be quite long, then you can get movement artifacts, and that can distort the images that you get. In addition, using contrast for the dynamic contrast imaging, that can be a problem because patients don't want to have gadolinium these days. There's all the issues with that. So there are going to be challenges to this stuff, and there's limited availability of some of this technology across different scanners. But all in all, I would say that the future will lie with quantitative imaging to provide a more objective report. Thank you very much for listening.
Thank you so much for an excellent talk. Now I'll request the chairs to please give their valuable comments. Professor Mohammad Ahmed Saeed and Professor Afzal Hamdani. I'm sorry, due to shortage of time, we'll be skipping the Q&A section. You can meet the speakers during the lunch break and ask them questions directly.
Thank you to all speakers, starting from Dr. Terence Gibson. So yeah, I think yes, the burden of back pain, inflammatory back pain, luckily, so our center was able to conduct a community-operated program for control of rheumatic disease grant on the prevalence of inflammatory back pain in the community and axial spondyloarthritis just a couple of years back, and we have published last year. So 20% is the prevalence of spinal pain in the community. 1 in every 5 person is suffering from spinal pain, which is a huge number looking at a country of 225 million. So secondly, the inflammatory back pain in these patients overall in the community is around 6.6%. And the axial SPA, as per the ACES criteria, was found to be in 1%. So you can imagine the burden. So this talks by other speakers, so I would really like to highlight a very wonderful talk as always by Dr. Haroon on uveitis. I have few questions which I will pick his brain during the lunchtime. So because of the time constraint, yes, our speaker, which is like Ali Maaz, who has come all the way from UK, he has really taught us about what the future of imaging in axial spondyloarthritis is. This era from where there is a lot of subjectivity, we really need to move to more objective measures for detecting inflammation in our patients. Thank you, Maaz. It was very enlightening.
Thank you.
I would now hand over to Afzal Hamdani for his comments.
Thank you very much, Dr. Saeed. First, congratulations to the PSR organizers, and especially Dr. Sara, I am not seeing. She did very well in Shalimar Hospital. In first 2 years, she managed to do a lot of work, even PSR conference she managed. I remained there for 3 years due to some reasons. I was not supported there. I will not mention those reasons. However, regarding the session, it was an excellent session. Regarding the pain management, I will request at some time later in the session, because the fibromyalgia is not addressed there. Fibromyalgic pain is one of the worst pain I have seen in Pakistan, and patient is never, or they have other problems also, depression, anxiety, and I have seen 2 patients who tried to do their suicidal attempts. They did suicidal attempts there, and they have only fibromyalgia. So Dr. Gibson, I will request later on to kindly throw light on this topic. Dr. Haroon, as usual, I am respecting him regarding his research work, up to date, and he has highly impact factor articles, and I have given few slides to him, few photos to him. Might be there will be no time to respond to those. And our other guests from the overseas, I give them the also, they have updated us. Thank you very much.
Thank you so much. Now I'll request the chairs to please come for distribution of the shields. So I'll request both the chairs to come for the distribution of the shields. I'll also request Professor Dr. Nigat Mir, Professor Sumaira Farman, Professor Abid Farooqi, and Professor Wajahat to join them. So the first shield will be for Professor Dr. Terence Gibson. The next for Professor Muhammad Haroon. The third one for Dr. Sulaiman Khan. Next shield for Dr. Maaz Ali Abbasi. Please don't forget to fill your feedback forms in order to claim your credits, CMA credits. Now I'll request Professor Nigat Mir Ahmed and Professor Abid Farooqi and Professor Wajahat and Professor Sumaira to give the shield to our chairs. Please don't forget to fill the feedback forms and go to the desk of executive members at the back to give your dues in order to attend the AGM. Now Professor Nigat Mir, Professor Abid Farooqi, Professor Wajahat and Professor Sumaira will give the shields to Professor Muhammad Ahmad Saeed. Shield for our chair, Professor Ahmad Saeed. The next shield for Professor Afzal Hamdani. Everyone, the lunch is served in the Grand Ballroom B, so please do lunch and come back at 2:45 or 2:50 p.m. before we start our last session. Thank you.